Okay, so this is Mr. Garcia. So I just want to take you through the life of Mr. Garcia as he's a member in our program. So at the top, you'll see that he will get a house call with a full health risk assessment within 30 days of enrollment in the plan. Now, if he has a primary care doctor that he has identified for us, then that information goes directly to the primary care doctor. So, hello, doctor, your patient has enrolled in our health plan. We have sent a nurse practitioner out to see them. This is all the information that we've gathered from the home environment, from the caregivers. These are the medications that he's actually taken, because we sit at the kitchen table and go through all the medications. We look at the bottles. We talk to them about the meds that they're taking. That information gets back into the health information technology system, and we risk stratify. So we will level our members between levels 1 and level 4, 1 being the most healthy members, 4 being the sickest. So the number of touches that they get and the care team, the interdisciplinary care team that's assigned, depends on how sick they are, what level they are, and what their needs are. They receive a customized plan of care. The MedAssist program, which I just talked about, will look for new diagnoses that were found in the house or within the claims and get that information out to the providers caring for the member, get them assigned. This member may be assigned to a high-risk heart failure team because he happens to be a heart failure member. And that means that we can deploy things in the home like telescale technology, where a scale is placed in the home, member is taught to step on the scale every day. It will weigh him, it will ask him symptoms questions, it will help avert that hospitalization that could happen if the care is not coordinated. The information comes back through our health information technology to the care coordinator, who can then get the information out to the primary care doctor and get this Mr. Garcia treated before he winds up in the emergency room. And then if he does happen to have a hospitalization, we look at the transition of care. So when the member goes home, we will deploy a nurse practitioner or an RN back to the home, again with the XL Care technology, with a tablet, to look at what were the gaps in care, what caused the hospitalization. They can do a medication reconciliation between the hospital discharge meds and what he was taking previously, and make sure that everything happens as it should following the hospitalization, which is found to be a huge improvement in preventing readmissions at the transition of care. We also employ dietitians. So in the chronic illness population with chronic diseases, diet is hugely important. So the dietitians work with our members via phone on their diet and look at the prescriptions via their doctors and help them learn how to manage their disease. So now I'm going to talk about the impact of our programs on medical costs. So we have definitely seen some pretty dramatic improvements in costs as well as in clinical outcomes. And so we have some graphs to show you and some different outcomes. So next slide. So these are outcomes actually in our CSNP population. Our dual eligible population is on the left, and the non-dual eligibles are on the right. So we looked at our members. This is actual member data. And if we looked at them from enrollment from 2007 through 2010, and if we had not employed our care management programs and all the things that I've just talked about, what would their medical cost look like over time? And so the dotted line is what we would expect to see the cost be if it was not adjusted for the medical trend, and then what happened to those actual members as they were enrolled with us over time and our care management and medical management programs were employed. And you can see a pretty dramatic decrease in their PMPM costs. Dual eligibles, a more dramatic increase than the non-duals, but in both sides of the equation in the CSNP, very, very nice decreases in their PMPM costs. And these are 30-day readmissions, 30-day all-cause readmissions. So it's on the radar screen of all health providers now, hospitals as well as physicians, to decrease hospital readmissions. So we look at 30-day all-cause readmissions, and we looked at the impact of our programs on readmissions, and we can see that if you look at the dotted line, and you look at readmits per 1,000 on the left, as well as the percentage of hospitalizations that are considered readmissions, both very, very nice decreases And these are the outcomes that we're seeing with our programs. Another thing that we're very proud of is our medication adherence rates. So we know that if patients take their meds, that they're going to do better. They're going to have less hospitalizations and less mortality, morbidity. It's very difficult for folks, especially when you talk about our demographic, to remain on target with their medications. That's one of the reasons why we have such a robust pharmacy program. So we looked at our outcomes from 2010 to 2011, and we looked at adherence on 3 major classifications of meds: diabetes meds, ACE inhibitors for hypertension, and statins for cholesterol. And these are 3 of our largest markets: Arkansas, Missouri, Texas, and South Carolina. And you can see really, really nice improvements in adherence in all 3 drug classes, in the high teens and low 20% improvements from one year to the next, which is just huge, and we believe demonstrates the value of the pharmacy programs as well as the care management that we do. And that's the end of what we have to say, but we really believe that health plans have a role to play in the management of chronic diseases, but you can't do it without a very strong platform in health technology.
Thank you, Laurie.